Hi everybody. I want to share a lecture that I recently researched and created for the residents that I am helping train in my fellowship. The lecture is called Black Moms Matter, and it's a look into the racial disparities that underlie the maternal mortality rate in the U.S. Profound racial and ethnic disparities have been documented in many areas of health and healthcare. As doctors, we have a responsibility to attempt to rectify these inequities, and any attempt to do so has to start with an accurate account of prevalence. We each have a responsibility to call out the inequity that we see in the details and the big picture of the corner of the world that we live in. For me, that's women's health care, and there's no statistic that's more concerning or that highlights these disparities more than the maternal mortality rate in the U.S. The U.S. is one of only 13 countries worldwide that actually has a rising maternal mortality ratio. It's the only country with an advanced economy where the maternal mortality rate is actually getting worse. Black women experience this statistic very differently than white women. Black women die at a rate that's 3 to 4 times greater than white women, and that's regardless of income, of education, of geographic location. They're also 2 to 3 times more likely to die of the 5 major conditions that are implicated in severe maternal morbidities. So in a national registry of women diagnosed with preeclampsia, eclampsia, postpartum hemorrhage, placenta previa, placental abruption, Black women had a case fatality rate which was 2 to 3 times higher than that of white women. 700 to 900 women die of pregnancy or childbirth-related causes every year, and some 65,000 suffer from severe complications. Of those, Black women account for 43 out of every 100,000 live births, and white women only account for 12 deaths out of every 100,000 births. The Center for Disease Control and Prevention estimates that about 60% of maternal deaths in this country are preventable. For years, hospitals have blamed this rising maternal mortality rate and injuries on problems that are beyond our control. We say that, there's poverty, pre-existing medical conditions, women are getting pregnant at later ages, and that's why America is the most dangerous place in the developed world to give births. But the data, the statistics don't support this. Most of these deaths are preventable, and a lot of the data and medical records implicated in these maternal deaths show a complicated mix of misdiagnoses, delayed care, and a failure to follow safety measures. So I want to highlight this topic, and I want to delve into some of the nuances that could potentially inform our understanding of the maternal mortality rate in the U.S. and the uneven share of that maternal mortality rate that Black women have to shoulder. So to start by just highlighting what health disparities are. Health disparities are inequities that result in disproportionately higher rates of death, disease, and disability, and they have adverse consequences on the physical, mental, spiritual, and social well-being of population groups who historically and currently don't experience equivalent social advantages. There are disparities across the board in obstetrics and gynecology, whether that's looking at the infertility rate in the past 12 months, the unintended pregnancy rate, the preterm birth rate, the fetal death rate, the maternal mortality rate, rates of sexually transmitted infections, rates of cervical cancer, breast cancer deaths, diabetes-related deaths. All of these diagnoses highlight disparities in health outcomes between Black and white women. To go back to what I previously said about this maternal mortality rate, is 60% of these deaths are preventable, and as opposed to focusing on the grand majority of these deaths that are preventable, hospitals, the system, really like to try to blame women for their deaths. They like to say that patients they were sick, they were old, they had poor access, etc. But To quote one of the policy papers I read, to prevent women from dying in childbirth, we first have to stop blaming them. We have to recognize that the maternal mortality rate in the US is 100% an outlier. It does not parallel other wealthy countries with similar rates of cardiovascular disease, of obesity, of diabetes. The emerging consensus from comparing the US to similarly wealthy countries with similar rates of coexisting medical morbidity is that the poor maternal health outcomes here are not in fact inevitable, but they're the result of laws, policies, and institutional practices which can and should be changed. Health is in part determined by factors above and beyond individual behavior or use of medical care services. And it's not that excellent care isn't available here, it is, it's just not reaching everyone. So, to further this point and to further show that this is not something that can simply be ignored as genetics or a biologic difference that leads to differences in maternal health outcomes, when we look at studies that compare foreign-born and US-born women of the same race and ethnicity, we find that foreign-born women actually have better health outcomes during labor and delivery than US-born women, despite their later initiation of prenatal care and less education. And this holds true both for the Hispanic population and for the non-Hispanic Black population. And we also find that with acculturation, which means with generations of women living in the US, with the change in identity from identifying as being from there to identifying as being from here, with your mother tongue changing from being Spanish to being English, or being an African language to being English, we find that the health outcomes actually become worse and mirror that of the non-Hispanic Black community here in the US. So it does beg the question of what is it about the lived experience of being Black in America that lends itself to these poor health outcomes. There's a lot of focus on a word called epigenetics, which means the way that our lived experience is imprinted on our genetic material and the possibility to pass on those lived experiences. A very significant proportion of the women that we're talking about are descendants of generations raised in slavery or subjected to virtual serfdom. In the US, there is a disadvantage of a legacy of historical exposure to extreme discrimination, and certainly a current experience, a current lived experience of ongoing marginalization and limitations in access to opportunities. Structural racism can impact every aspect of a person's reproductive experience, from quality prenatal and pregnancy care to parenting children in a safe and sustainable community to access to abortion care. And we see this highlighted with the disparities in the stillbirth rate and the preterm labor rate, in the percentage of women who deliver a growth-restricted fetus, to the maternal mortality rate, and then also to the access to prenatal care rate. And even looking at the C-section rate between Black women and white women, Black women being more likely to have a C-section than white women, even after adjusting for all the other variables that we know and recognize to be risk factors for a C-section. So to pose a question and say, well, if we can't explain this by factors related to the health of these individuals, what are we not capturing by the data? To answer that question, we first have to look at our data and see what are the faults of our data. There's two major problems with the data that we collect about the maternal mortality rate and racial disparities. One is that the definitions across the board are not consistent. The CDC defines maternal mortality rate as the death of a woman during pregnancy or within 1 year postpartum, while the WHO only uses a definition of pregnancy or up to 6 weeks postpartum, and from state to state their adoption of definitions is different. The data is a mess and it likely underestimates the numbers. We don't consistently collect data in the US across states about how, when, where, and why women are dying, which means that we are already starting an endeavor to target fixing this problem at a disadvantage because we don't even fully grasp the extent of the growing problem in our nation. The other thing about the data is that a lot of our data, our research methodologies are not targeted at understanding racial disparities. It's often a secondary outcome, an afterthought to say, well, let's stratify for race and see if that makes a difference. But we're not using research methodologies off the bat that are primary objective is to understand racial disparities, and that certainly puts us at a disadvantage as well. Another question I'd like to answer is to answer the question of why is pregnancy dangerous, and what is this interplay between pregnancy and race experiences that puts women potentially at a higher risk, that puts Black women potentially at a higher risk of dying from pregnancy. So there's one theory that is important to understand, and it's a theory of chronic toxic stress. So pregnancy, the physiology of pregnancy is that it's an acute stress on the heart. There's an increased blood volume, there is an increased heart rate that can exacerbate elevations in blood pressure, cardiomyopathy, arrhythmias. Women have to be able to accommodate this acute physiologic stress during pregnancy in order to carry a pregnancy, go through delivery, and the postpartum period safely. For Black women who are subjected to chronic toxic stress, this weathering hypothesis, a look at the environment that molded your stress response from childhood and the environment that you continue to grow up and live in, it's this wear and tear hypothesis, essentially that your autonomic nervous system, your hypothalamic, pituitary, adrenal axis, metabolic, and immune systems, which are responsible for managing acute stress, they actually, from chronic wear and tear, end up having a poor milieu to adapt to acute stresses and affects a woman's ability to deal with the physiologic strain of pregnancy. There's also a historical context that's really important, specifically in women's health, that all practitioners, I think, need to understand when dealing with and treating a patient and caring for a Black woman during labor and delivery, is that there is a bleak and a depressing history behind disparities in Black maternal health in America. Black slaves were forced to breastfeed their white masters' babies, and if pregnant, were expected to work in the field right up until their labor and go to work immediately after with the babies strapped to their backs. That is a reality that cannot be removed from the narrative. There's also a very real and depressing reality for how we obtained gynecologic knowledge, in that the father of modern gynecology, Marion Sims, developed a lot of the surgical techniques that we use today by experimenting on female slaves. So there's certainly past abuses of Black women's reproductive bodies that live on, with a fear of harm, a fear of coercion. To quote one of the studies I read, being Black here is not really the risk factor, racism is. And both the chronic toxic stress of racism, as well as the way that racism infiltrates and finds its way into the hospital. To again state, most of these deaths are highly preventable. When serious complications like hemorrhage or stroke are quickly identified, monitored, and treated efficiently, women are very likely to survive them. Even when health care is accessible to them, Black women may not receive appropriate, timely, and quality care on an equitable basis, and we have data that supports this. It shows that Black women are treated differently than white women. Despite reporting the same symptoms, they receive fewer diagnostic and therapeutic interventions and even receive less pain medication for the same pain scores. So whereas some disparities in other contexts, you can argue an origin in biology. You can say, okay, well, there are some genetic polymorphisms that are more common in Black women, like sickle cell. That is not the case here to explain the maternal mortality rate and the disparities for the most part, that we're seeing in obstetrics and gynecology. A great many more are rooted in maternal health behaviors, physical and social environments, and all of these things should be viewed as targets for change. Which begs the question, well, what's in our locus of control? Like, what can we as providers control, and what are some action items that we can take away? So I've compiled a list. These by no means come from me. A lot of them come from the Black Mamas Matter Alliance, and some of the research articles that I read, both that are published in Obstetrics and Gynecology and the Journal of Obstetrics and Gynecology on racial disparities. And I compiled from all of the different sources I reviewed some action items that I'd like to highlight. So one, the first thing is that we need to cultivate research to advance care for Black mothers, and this means funding research and research methodologies that teach us about reducing disparities not as a secondary objective, not as an afterthought, but as a primary objective, with a goal of reducing the overall rate of poor maternal health outcomes. Sure, but more so to specifically understand the interplay between race and the way that women experience that maternal health outcome. There's also a necessity to fund family planning services and women's health programs. We cannot expect optimal outcomes from dismal beginnings. So a big part of this is really noticing your own language and behaviors and putting the responsibility on yourself to get an education on implicit bias, on class and gender bias, anti-racism, and human rights, essentially reproductive justice in the practice of women's health care. And to take it one step further, to not just educate yourself, but to spread that education to your colleagues and, in fact, demand that training happen on an institutional level. Other interventions that are within our locus of control that can help reduce these racial disparities are, one, to support organizations led by Black women in reducing this disparity. There's a lot of organizations like the Black Mamas Matter Alliance that have been working on this for a long time. We need to ensure that we support Black women in having a voice when it comes to the policies that affect their health care. We should demand diversity within administrations in hospital settings and also in political office. We also need improved monitoring and accountability mechanisms for preventing maternal mortality. And there is a role for advocacy and legislation. For example, California and New Jersey both have bills specifically targeted towards doing just this, towards improving the racial disparity in poor maternal health outcomes by requiring implicit bias training, by requiring the Department of Public Health to track and publish data on maternal mortality rates, and to further this reduction in pregnancy-related preventable death, severe illness, and associated health disparities. They're essentially bills that say this is important to us, this is a focus, and we're going to support interventions that help. So that's really all I have for you guys. I'd love to hear from anybody who watched this. If you have any experiences of your own, I'd like to kind of challenge any healthcare professional to call out the implicit bias that they see in their corner of healthcare, to call out the disparities that are present in the pathologies that they treat, and then certainly to share that knowledge with us and to make a donation to the organizations that are moving the needle on these topics. So for me, I'm going to support the Black Mamas Matter Alliance. I'm indebted to the toolkit that they've put together and the resources that they share. It was definitely a launching pad for me to start learning about this and to be able to put something together for my colleagues to teach them about it. So I look forward to hearing what all of you guys do and can share with us, and just praying that this is all the start of us recognizing racial and health disparities and changing a system that has allowed this to happen for so long.